is very helpful, but the use of MRS in spine surgery is relatively new. This is so because previous studies using 1.5 Tesla MRI was not very successful, but now with 3 Tesla MRI, we can see some changes. These MRS studies can show us that we can see higher MIO-I and glutamine changes. And this suggests MIO-I could potentially be an early marker of spinal cord inflammation and early stage of demyelinization in cervical stenosis patient prior to neurological impairment. MRS can show us some changes in late stage also. You can see here changes in NAA peak, choline peak, and MIO-I peak. You can see here pixel place should be located in the coronal pictures. In a recent study, some researchers used MRS and DTI in the same patient group, and they showed that the use of both these techniques in same patients can increase the diagnostic value of studies. So another technique is computed tomography. We use computed tomography in order to see OPLL and all other compressive bony structures. But a new 3D CT and MRI technique, this paper was published in World Neurosurgery, showed that 3D CT can show us occupying ratio and OPLL volume better than traditional techniques. For diagnostic purpose, you can use EMG. I think it's very important. This is so because EMG not only shows the spondylotic changes, but also can show us differentiation between ALS and cervical spondylosis, and therefore it may prevent unnecessary surgery in cases. Somatosensory potential can be used for diagnosis, but the most important is, as we have seen in dynamic MRI, extension may deteriorate the patients. Therefore, somatosensory potential in extension position can show us some changes also. I go to surgery. This is a paper by a big group of AO spine. This is a very good paper. I think it shows evidence very good. And as you can see here, they recommend us surgery for severe myelopathy and for moderate myelopathy. But for mild myelopathy, even if there is radiologic spondylosis and even there is some signs of myelopathy in MRI, they do not recommend surgery. Therefore, we can say if there is no myelopathy, no surgery. Surgical options include many anterior and posterior approaches, and you can see here we can use ACDF or corpectomy in some cases, oblique corpectomy, skip corpectomy, and as a new surgical modality, ACAF, I will talk about it, and there are many posterior procedures, and I will show you 2 videos for this also. ACDF is, I think, very simple but very effective procedure to relieve focal and monosegmental compressions. In these cases, I do not use any plate. 1 cage is enough in most of cases. But if I do surgery in many segments, then I put plate in order to stabilize the cervical spine. And if compression is behind the cervical vertebral body, then you need to do corpectomy. If there is a unilateral compression, an oblique corpectomy can decompress the spinal cord and nerve root very effectively. This is also an attractive procedure. Skip corpectomy is another technique which we use in many cases. As you know, if there is indication for 3-level corpectomy, you can do 3-level corpectomy, and in order to prevent late complications like this, you need to do a posterior plus anterior stabilization. In order to prevent a posterior surgery, you can do a skip corpectomy. This consists of 2-level corpectomy and the compression of the posterior of the middle vertebra. This provides good decompression and fixation using 6 screw and no posterior stabilization. You can see here the compression type, and with placement of the screw, the screw can bring vertebral body to the front. This is one of these cases. Another technique introduced recently for OPLL is anterior controllable anti-displacement and fusion. This technique was introduced, as far as I know, by Chinese neurosurgeons, and was published in World Neurosurgery. In this technique, you should accept OPLL and vertebral body as one complex. That means in order you should slide all this complex to the front, and for this you do discectomy here, and then you remove some part of the anterior aspect of the vertebral bodies between, and then place the screws and plate. Then from the sides you open 2 grooves, and then you bring all this back to the front. This is a new technique. I think this is a little demanding, but for OPLL cases can be used. This is pictures of this paper. They are not my own paper cases. You can see before surgery and after surgery, and this is also MRI before surgery and MRI after surgery. You can see CSF in the front of the spinal cord. Another techniques are posterior techniques. You can do total laminectomy. Actually, we do not use commonly, almost never use total laminectomy without stabilization. But sometimes in patients with high comorbidity, it may be an option, but these patients should have stiff cervical spine with preserved cervical lordosis, no radiographic evidence of spinal instability, and we should be very careful in order not to violate the facet joints and muscles. We know laminoplasty. This is a very well-known technique, but I don't want to talk about it. And we use actually commonly in our department laminectomy and stabilization from the posterior. And you can see here, in this technique, you can provide also lordosis. We almost never use in the Kerrison or high-speed drill, we use laminectomy using ultrasonic bone scalpel. This is one case with the MRI and CT of the case before surgery. I would like to show you a short video. We open the holes for screws first, and mark it, but if we do not place the screws, then we disconnect vertebrae, cutting the interspinous ligament, and then we using ultrasonic bone scalpel, we do laminectomy. As you know, high-speed drill may cause heat injury sometimes in spinal cord. This is a risk. And kerosene also is very dangerous. Therefore, we use this technique. We compared the results of this technique with the results of the high-speed drill, and our studies showed that laminectomy using ultrasonic bone scalpel provide easier, faster, and safer decompression of the spinal cord. In this technique, probably maximum a laminectomy takes maximum 10 minutes for 3 levels. What we do, we cut the lamina first superficially, then we cut deeper layers in both sides, and then we remove the lamina totally. You can use ultrasonic bone scalpel for all laminectomy procedures. We use it routinely for intradural tumors also. Then you can do laminoplasty. You can fixate it to the main lamina, to facet, and there is no gap when compared to high-speed drill. And finally, we cut ligamentum flavum. After completing the compression, we use ultrasound. As you can see here, we try to see anterior subarachnoid space in order to understand if there is enough decompression. Okay. You can use this technique for unilateral unilateral approach for bilateral decompression. As you know, we operate patients with lumbar spinal stenosis as well. And for lumbar spinal stenosis, we use unilateral approach for bilateral decompression. Ultrasonic bone scalpel provides opportunity for similar procedure. For this case, we used a bilateral stabilization, but if there is no indication for stabilization, you cannot. You can open only one side. You can see removal of the one part of the lamina. This is a kind of tailored decompression.
Sait, can you please go quickly on your videos because we're running out of time?
30 minutes,
Okay.
30 seconds. Okay. Okay, you can do further the compression using high-speed drill for other side. Is possible. Okay, we have no time. Therefore, I would like to show only combine the compression as well. So in summary, MRS and DTI seem to be promising in diagnosis of cervical spondylotic myelopathy. Dynamic MRI, CT, and SEP give information about the dynamic aspect of the disease, particularly in extension. Ultrasonic bone scalpel provides safe, easier, and faster laminectomy. Hemilaminectomy and bilateral decompression are good options in cases with good sagittal parameters. And in these cases, unilateral or bilateral stabilization can be performed. Thank you very much.
Thank you. Thank you very much for your presidential lecture. So since we are a little bit, we are on time actually, so we're gonna pass to next session. But I'd like just to make an announcement for young neurosurgeons. Please register your team of 2 surgeons for the quiz in the afternoon. And for the quiz, Are You Smarter Than Ned Benzel? That is going to be in the afternoon. And you will have the possibility for doing that to become a member of the World Spinal Column Society and well, having a personal picture with Professor Benzel and Professor Sait Naderi and the certificate of participation. So I think it's going to be fun as well. So thank you for attending this session, and we're gonna have the main topic sessions in 3 different rooms. So in this room will be about cervical spine deformity, and the chairs of this session will be Greg Trost and Mario Gomes. Thank you.
We're moderating together. Do you want me to start and then we can alternate introducing people or whatever you'd like to do? Okay, okay. Okay. So is mine.
I can vouch for that.
Let's do this. Let's throw my name down.
I heard him talk yesterday. I don't see
If not, you may get a half hour.
I have been found out some information. My talk is shorter than it's supposed to be. My talk is longer than the time allotted. So,
Is Dr. Pitson here? Ah, alrighty. We just want to make sure we had all the speakers. So if we could have the speakers all come up on stage.
Good. Problems? So, hi.
Great, Greg Trost. Nice to see you.
Okay. No, any problems? No. Any problems?
No.
Okay.
We're good. We're just a little. So in the trying to keep us on time, I think we'll get going today. My name is Greg Trost. I'm from the University of Wisconsin in Madison, and I get to do some of this stuff because Ed Benzel and I have been working together on these hands-on review courses in Cleveland for 20 plus years now. So our session is on cervical spine deformity, and I apologize for my voice since I was yelling at a lot of people during the pre-meeting course. But we have four excellent speakers today, and we're going to start with Dr. Tobias Pitzen, who's going to talk to us about clinical cervical spine biomechanics.
Good morning, ladies and gents, and thanks, Dr. Trost, for inviting me. I think it's a hard topic to talk ahead of Ed about cervical spine mechanics. Everybody knows his impact worldwide on cervical spine mechanics, and fortunately my topic is clinical cervical spine mechanics. So I thought about how to manage that major problem, and I took the following solution. I will talk about biomechanics in the next 10 or 12 minutes concerning specimen, fixation test machines, load displacement, hysteresis, and stuff like that. And so that it's not too boring for you under clinical aspects, including some other papers and some of mine. And the first topic I will be talking about mechanics is ACDF with plating. We heard that Dr. Naderi doesn't use plates in monosegmental fusion. My opinion is completely different, but I'm just focusing on mono versus bicortical fixation. This was one of my first papers I published in the 90s. Well, you may be connected with the name of Dr. Kasper. Kasper was my teacher for 12 years in Homburg Saar, and this is one of his intra-op shots. So how he brought down the screws down to the posterior cortex. This was one of his credos, so to say, just coming from Jörg Böhler from traumatology and long leg bones, and then was transferred to the posterior cortical shell by Wolfert Kasper. But there have been, at that time, a couple of papers been out by Reichenstein and Clausen from Northern America, just showing that the bicortical fixation can be a certain risk. And the risk was defined as creating an epidural hematoma, creating a dural perforation, or creating a spinal cord damage. And also this has been written in the literature seldom, but if you never saw a case like that, or if you never would experience that this happens, I can tell you it happens more than you would expect. So I'm working in Langensteinbach, and we see there a lot of revision cases, and this was one of the last week, where this screw, believe it or not, was for 10 years in this position, and it was done with intraoperative fluoroscopy. And I couldn't believe how, but it was really done. So I had to remove this screw after 10 years, and this was a topic why Dr. Kasper just asked me to develop a monocortical screw. So we did that in 1997, and I did test that together with Achim Wilke. And just to show you how works that thing, spinal biomechanics, I just go a little deeper in this stuff. So if you would like to be influenced with spine mechanics, you usually need human segments, as I show you here. You freeze them, you thaw them. If you have enough, then you go to a lab of your wish. You anchor the top and the bottom level vertebra in PMMA or dental stone. You divide them in groups with comparable age and bone density, and then you do what you want to do. So in this case, you test the monocortical versus the bicortical. And this is one of these test machines. This is, has been performed by Achim Wilke in the mid-90s in Ulm, and this is where I did the experiment. You can see how this specimen is fixed here, and you can see how the motion is monitored via this motion analyzing system. So you usually, if you want to ask how stable a system is, you ask for the three-dimensional stability. And you measure the three-dimensional stability as a function of motility, which means if it's more mobile, it's less stable. So it's just vice versa. And you just check it in 3 axes: flexion, extension, left-right axial rotation, and left-right lateral bending. And you apply not a force, because a force is acting along an axis. No, you apply a pure bending moment. The difference is a bending moment is introduced via a lever arm. You can see them here on this machine. And it's applied, it's introduced perpendicular to the motion axis. So that's a big difference. So you do that, and then you store all these ranges And here you see the results. You see that in this experiment, the monocortical screws, they are in green with respect to the intact range of motion, which is approximately in a human spine cadaver segment, 12 degrees. You can see that here, yeah. And there's no difference between the greens and the blues, so you can say as a first result, with monocortical screw fixation and anterior cervical fixation and plating, you get the same stability with the bicortical. That was dramatic at that time. The second study, because I was attacked for that study several times, was I checked the importance of the posterior cortical shell. For this, I did not took segments, I took cervical isolated vertebrae, and I divided them again in 12 to 12 with the same level and comparable BMD, and I put 12 in the group for torque testing. So that's what you do if you insert a screw. You say, hey, I'm great, it's good bone, and this screw will be strong. And I pulled them out in another 12, and I used the same screws in length and diameter for that experiment. So this was our experiment. I did embed the cervical vertebrae into PMMA here, and then I applied 2 drill holes as you do it in real surgery, and I removed the cortical shell in one and I left it in the other, and then I torqued, I fixed, or in the second trial raw, I pulled them out. So you can see one of the original specimens, not original specimens, just to demonstrate what we did here. So we took out the posterior cortical shell with the diamond drill here, so that the posterior cortical shell was taken out from the experiment. What we did here now, in contrast to the other experiment, we did not test initial 3-dimensional stability. We are talking about clinical cervical spine mechanics. Yeah? We did test the torque with a screwdriver, and this was done by a computer. And we did analyze in the second trial the pull-out force with other screws, and with testing pull-out force, it's important that the pull-out force is applied along the axis of the screw. This is in fact from my field as reviewer for a couple of journals, one of the methods where I put out the paper. If the guys who wrote the paper and submitted to me cannot show me how they did that, then the paper is bullshit. Because it makes a big difference if you pull it out that way or that way. Okay, so the results for torque for monocortical versus bicortical were again the same. So there is no difference if you fix them monocortical or bicortical. And for pull-out, again, there is no difference if you fix them monocortical or bicortical. This was again surprising. So if you apply screws to the posterior cortical shell, it just makes the procedure more dangerous. Next topic, when do we need additional posterior fixation? I had the pleasure to do that with Tom Oxland in Vancouver. What we did is we wanted to check when there is the point that you need in trauma additional posterior instrumentation. We tested these specimens intact, then after discectomy, applied a plate, and then cut the posterior ligaments. And you see here a result as a hysteresis curve, which is you apply minus 1.5 Newton meter to plus, so in the sum 3, and then you measure the degree. So this is again 12 degree for a segment C5-6. And now look what happens. You cut out the disc and the hysteresis opens. That's what we call instability by a surgeon. Then you apply a ACDF and it's stable. So you have a stability of approximately 1 degree in each direction. Then you cut the supraspinous ligament, you see nothing. You cut the flave, you see nothing. You cut the capsule, you see an opening. You apply the posterior instrumentation and you see it's bulletproof stable. You open it and chisel the facets, it's again getting a little bit more unstable, and you install the posterior instrumentation and it's bulletproof stable. And here are these results together, and what you see is that as soon as in presence of an anterior plate you cut the capsules, then you should go for a posterior instrumentation, because this is unstable with respect to this. And the same is true for lateral bending, and the same is true for axial rotation, even more pronounced. So what you can learn from this is, as soon as in a trauma you have a complete cutting through the posterior elements, go for posterior if you apply plate. The last part of my topic is anterior cervical corpectomy and fusion. Nader reported about that, so our president. So when do we need posterior fixation in case of ACCF? Usually, what you're doing if you're doing an anterior cervical corpectomy and fusion, you create a rigid situation anterior and have a flexible posterior. This usually results to 30 to 50% in a failure, usually at the lower end of the construct. So look, these are 8 screws and they're anchored in cement, but it does fail. We know this from several papers by Foley, Roux, Steblick, Wang, Angelo, and they usually fail under extension. So if these guys are shaving in the morning, you have to take care of the cage. That's why in this guy, suffering from a rheumatoid arthritis, and that's nice kyphosis, you should, if you do a ACCF, apply a posterior instrumentation. Otherwise, it will fail. It even sometimes fails in cases if you have really big guys with heavy muscle forces, so as in that Russian guy, that a monosegmental ACCF fails. I could not get a good post-operative lateral X-ray because that guy was so massive, but I promise you that I'm not so stupid to fix it in that way. It did happen after a couple of days, and I had to remove another vertebral body because this one was completely destroyed by that, and then put a posterior instrumentation, and now it's solid. Another topic where you should go to a posterior additional instrumentation in spinal mechanics is at the junctional regions. So in junctional regions, you have a traumatic change in anatomy and mechanics. Take care, you need a longer fixation here. If you don't do it, you will have some really bad experiences. Like I had approximately 15 years ago, just operating that single mat of an esophageal cancer, and I did it in that way, and it was really nice. You see the wound drains here in place, and you see what happened after a couple of days. So I did over-instrument it, and I learned from this. Was my first case when I failed in one single ACCF combined with posterior and junctional regions. This is a contra example for a young female with the rheumatoid arthritis with an intermitting coma and a paresis of the 6th cranial nerve due to that pseudobasilar impression. So I applied a halo, I pulled it several times, and then I fixed it in that construction. And this is the 3-op post-op, and you see that I applied a halo too because I did not trust the weak bone and that lot of metal. And then it healed completely. And you see that it's 1 year after, and it healed without any loss of correction. I summarize. There's a need to know, and I hope I could show you that, to know some basic mechanics in spine. Look at spine fixation. And just to summarize my talk, MC is a stabilized species screw fixation in ACDF. In trauma, additional post-fixation in the presence of an anterior plate is needed as soon as capsules are gone, and even more if the facets are gone. In junctional regions, add posterior fixation. If more than one vertebral body is resected, go posterior too. I hope I did not bore you too much, but I thank you very much for your attention. Thank you.
Let's hear now Dr. Eduard Benzel of Cleveland about cervical spondylosis and cervical spine deformity.
If we have time, we'll do some questions at the end. So if the speakers would please stay in the room until
Tobias, you might want to sit up there. And Giannis, you come up on the stage. So I'm talking about myelopathy and deformity, and I'd like to emphasize up front that all instrumentation cases are deformity operations. With surgery on the spine, you have an opportunity to prevent deformity, correct deformity, or cause deformity. And be very wary of every case and try to establish normal alignment. This patient had decompressions and fusions, both of which ended up with a kyphotic posture. This is a very poor outcome for the management of cervical spondylosis. Cervical spondylosis is essentially manifested to us as surgeons by myelopathy or radiculopathy and deformity. Each of these patients has a similar posture. They all have a fixed cervical kyphosis. They all have, and they each complain of two things. The first is the kyphosis trapezius sign. Note the hypertrophied trapezius muscle. The trapezius muscle is an accessory muscle of extension. It's not very effective, but when the neck cannot get back into its normal posture, the trapezius muscle is reflexively activated, causing significant discomfort in myofascial syndrome. But they also complain of back pain. Here's a patient with who is fused from the occiput to the thoracic spine and has a significant upper cervical downward bend or kyphosis. And you can see her leaning backwards to look forward, and her plumb line drop from C7 falls far behind the lumbosacral pivot point or the hip. A couple of terms that I think are relevant for cervical deformity. The cervical sagittal balance, or another way of stating it, the cervical sagittal vertical axis. It is the measurement from C2 to C7 in the standing position when plumb lines are dropped. It should be less than 10 millimeters in the normal youthful spine, and when it approaches 40 millimeters or so, as depicted on the right side or in the lower right picture, we can see significant problems with spinal pain and health-related quality of life measures. Another important variable in this area is the C23 slope or angle. In the standing position, C23 disc should be horizontal to the floor in the normal spine, as should the L34 disc be parallel to the floor in the standing position. When it's not, it becomes a very vulnerable joint, particularly as depicted on the right, when there is a long fusion taken up to C3, but not to C2. Another important variable is the C7-T1 angle, or what more commonly is known as the T1 slope. It is the angle between the C7 and T1 disc interspace. If it is relatively horizontal, the C7-T1 joint is not so vulnerable. On the other side of the coin, if there is a significant angle and long fusions are taken from high in the cervical spine to C7, this becomes a very precarious situation. I already showed this patient. A patient presents with myelopathy, progressive myelopathy, and a lot of neck pain, as I outlined earlier. She has some signal change in her spinal cord at an area where there is really no ventral or dorsal compression. This case is about almost 20 years old for me, and so this was early in my course of evaluating patients with deformity and cervical spondylotic myelopathy. Regardless, we felt that we needed to correct her deformity. We saw several areas in her spine where she angled and moved, and so we used gravity and viscoelasticity to help correct her deformity. Viscoelasticity is the principle by which the application of a constant load, say for example the weight of the head moving backwards, causes gradual deformation of the spine. So if we put a log roll under the shoulder and a pillow underneath the head and do our operation and begin loosening the spine and doing discectomies, etc., and using Caspar pins to correct deformity, we then can take the pillow out and let the head gradually lean or fall backwards. And one must have patience, particularly with dealing with these cervical and cervical thoracic deformities. We can also use trapezoidal spacers to gain an advantage when operating from the ventral location. We can bring the bone to the implant. If we retain an intervening point of fixation, i.e. a vertebral body, we can use that vertebral body to gain 3-point fixation instead of 2-point fixation, and we can correct deformity by bringing the bone to the implant. Here is a case in which that was done. This is our patient who started off with a 15-degree kyphosis and now has a 5-degree lordosis in her cervical spine. Of interest, even though she had no compression and a signal change at an area with no compression, her signal change disappeared with the decompression of the spine. Compare pre-op on the left with post-op on the right. So along the way, I saw several other patients, and I began thinking about this problem. And here we see a man who had a 70-year-old man who 10 years earlier had a laminectomy for cervical myelopathy, and he had good result clinically with resolution of myelopathy, but now his myelopathy is representing, and he's having increasing and progressive difficulty with ambulation. Here we see a atrophied cord, and a surgeon who's taking care of him sent him to me, and we're wondering what to do. Remember, cervical spondylotic myelopathy is a manifestation of repetitive trauma and tethering and distraction. So we got a flexion and extension x-rays. He really doesn't go into extension, but he does go into flexion at every segment. So his segments are mobile. We got a flexion MRI. So this is a strikingly different picture than his neutral MRI, as we see here, neutral and flexion. This is probably a good example of a post-laminectomy band or membrane. But regardless, every time he bends forward, he is dinging his spinal cord. So we knew we could correct this dorsally because he moved at every segment. All we needed to do was multiple level facet osteotomies, which were performed, and you can see them right here, corrected his deformity and fused him up to C3. So we thought we did a great job. His myelopathy immediately began to improve. His neck pain improved. But this is what he looks like down the road a bit. He began topping off at C2-3. Remember I talked about the C2-3 angle. His angle was tilted downwards, and we should have known. I wish I had have known then what I knew now. Going to C2 would probably not have increased the morbidity of the operation substantially, nor would it have reduced significantly his motion. But this downward tilt, plus the prior two surgeries, probably had something to do with his deformity. His original surgeon fixed him in this position, not a great position, but the patient with the stability improved significantly. My last case is a 32-year-old man who had a traumatic C7-T1 disc herniation. He was treated with this contraption at an outside hospital. The surgeon thought because the patient had neck pain, he should remove the implant. And he did, and gave it to the patient. And the patient brought it to my office when he came to see me. And this is his standing cervical spine x-ray. He's leaning quite forward. Notice how he is standing. He has got the kyphosis trapezius sign, so he's got horrible neck pain, but he's also got back pain because of this increased lordosis in the lumbar spine. So we did multiple facet osteotomies and loosened his spine up from the behind, so we basically took his old fusion apart, then turned him over, used trapezoidal grafts. We brought bone to the implant, and we used Caspar pins to help put the patient into extension, and this is what we see. I'd like to look at his neck and have the visual of what we can do if we correct deformity in severely disabled patients, those patients that are disabled by pain. And again, trapezoidal grafts are very important in this endeavor. So here he is pre-op, and not a happy camper. Here he is post-op with complete resolution of his neck pain and his back pain. I will quickly go through another case, a patient who had prior anterior and posterior operations, significant kyphosis. We did not want to do an anterior operation on her because of this, but because she had back pain and progressive neurologic deficit, we took her to the operating room and did a laminectomy, and we're going to do a fusion, but we couldn't see how good of a correction we got, and because we could only see down to about C2 on her x-ray, and we didn't feel like we had a great correction. This CT was taken about 6 days later with her placed in bed after closing her wound and putting her in extension using the principle of viscoelasticity, and then seeing that we